what did public health do wrong? What could public health do better? And it's a totally fair question. But if it's okay, we should just take a step back and look at the environment that public health is in and how that's changed. It's sort of like, how did public health steer the boat? But we should pay attention to the fact that the waves are swelling to 15 feet. There's, all kinds of dark clouds on the horizon, and the ship has a leak in it. Public health was underfunded for a long time. Where you would have a stable, reliable local media to talk to, that might have been gone. Social media within the political context was very, very polarized, and people were making, all kinds of claims about what public health was saying that's not true. And even responsible reporters were writing very sensationalist stories, what made it sound like public health was a lot more competent than public health was.
This is Dr. Chetan Sathya. Thank you for joining us for this episode of Northwell Health's 20-Minute Health Talk. We have an incredible discussion today from the co-authors of the book Information Sick. We've all recently been having conversations about how trust when it comes to public health is at an all-time low, right? People are feeling like there are so many divisions and we're not sure about the pathway forward. And we couldn't have a better set of kind of podcast guests today than all these co-authors here with us today. So we have Joanne Kennan, Joshua Sharfstein, and Lamari Morales with us today. Thank you for being with us.
Great to be here.
So, each of you has contributed so incredibly to the field of public health information and education. You have such storied careers, each of you, in such different ways. Joanne, I was going to start with you. Maybe just for each of you to comment on what got you interested in wanting to tackle public health messaging, storytelling, misinformation?
Well, I'm a journalist, and I've been a health journalist for something like 30 years now, both healthcare and public health, depending on where I am and what's in the news. And 5 years ago, I came to Johns Hopkins as the journalist in residence. I worked at Politico for a long time. I still write for them. I still write for other places. Josh and I it just started, I came sort of a year into the pandemic, and, the country was actually united at the very beginning of the pandemic across all sorts of the divisions that we normally have. There were a few brief weeks that did not last long when we were united. Not 100%, but pretty darn good. And I saw it splinter, and I saw the damage from splintering. And I also experienced this sort of change in the media environment. I watched more and more of my friends lose their jobs, and newsrooms get downsized, and the places we could get information changed, and there was more and more disinformation, and not as much as now, but even 5 years ago, it was beginning to be overwhelming. And I began to see how dangerous it was. So what led to our book really began as a course that Josh and I began teaching 5 years ago about this connection, this interconnection between the changes in our political economic changes in our media, the rise of disinformation, and what it really means to our health as individuals, how we access information and make decisions, and institutionally what it means for public health.
Incredible. And you were focused on health reporting when you were at Politico as well?
I was the editor at Politico that oversaw all the health coverage from the roughly 10 years, not quite, from the implementation of the Affordable Care Act and the messy implementation of the Affordable Care Act all the way through the pandemic, and also covering a lot of the politics of healthcare. Remember that 2020 was both the year that we were hit by the pandemic. It was also an election year in which health played a huge role, as it usually does in our politics. Earlier, I covered healthcare, whatever the big domestic policy issue of the year, but it usually was healthcare. In Congress, when I worked for Reuters, I was up there for almost 15 years. I always say I was there for 15 years, minus some time to make small people.
Incredible. Well, there's so much to drill down on there. Joshua, what about you?
Well, I've worked in my career in public health at the city level for the city of Baltimore, at the state level for the state of Maryland, and in the federal government at the Food and Drug Administration. And one of the things I've always been interested in is crisis. What happens when there's a moment of crisis? So many parts of our public health history have emerged out of crisis, and I've been in the middle of a bunch of them. And what I've noticed is that the experience of leading through a crisis has changed dramatically. And the playbook for communications in a crisis has changed dramatically. It used to be single communicator, very authoritative, able to answer everyone's questions, be first, be right, be credible, sort of the three key watchwords of the CDC's guide to crisis communications. But as the world changed, as the number of actual reporters at press events started to drop, and as people started blogging, and then now we have just a totally splintered world on social media, it's been very different, the experience. And I was at the School of Public Health already on the faculty during the pandemic, but I was in touch with many people who were trying to lead through a crisis and finding that the usual playbook didn't work, that people weren't believing them, that there was all kinds of falsehoods online, that there was even threats of violence against them. And it made me interested in both recruiting Joanne to the school, teaching a class with her, but also trying to make sense of this moment for the public health world so that we can be much more effective.
Wow. A lot of work to be done. And it feels like it happened so quickly.
Yes. I mean, I was the health commissioner of Baltimore City, and the Baltimore Sun was the local paper, and there were probably 5 reporters regularly covering the health department. There was one whose focus was just HIV, and you turn around and there's really not a dedicated reporter for the health department at the Baltimore Sun anymore. We now have a nonprofit newspaper, the Baltimore Banner, and it's just a very, very different world.
Well said. Yeah, to say the least. Lamari, what about you?
Thanks so much for having us. So I'm the communications strategist of the group. My own career started in broadcast journalism, and I worked in 2 of the 3 major cable news networks, and I saw some of the early polarization in the news media. And then I came out of grad school right when the iPhone came out, and I became really interested in the fact that organizations that had a lot of knowledge to share now had all of these tools through websites, social media, blogs, et cetera, to share their expertise with the world. And they didn't need to go through mainstream media as they had in the past. So I decided to kind of put my career in that basket and really focus on helping knowledge from knowledge-rich organizations, often mission-driven organizations, travel through all of these new tools and platforms, and had the opportunity to do that at the Gallup organization, which is the global polling organization, as well as an in-house consulting agency at Atlantic Media. And then now at the Bloomberg School of Public Health, I lead communications and marketing here. I've been here since summer 2019, just before the pandemic and through the pandemic. And now we have an environment where we have organizations sharing their knowledge, but so can anyone else out there can also share their knowledge, which has created or their lack of knowledge, or their perspective, or their hypothesis, or their falsehoods. And so we are now operating in this environment where there's so much information competing against each other from good players and bad and uninformed.
True. And I know we were speaking about this before we started here, but you 3 just do incredible work in this space. And I do encourage everyone to read Information Sick. There's just tons of learnings in there. Joanne, you mentioned that there were a few weeks of solidarity, right? At the beginning.
Not 100%, but nothing like the split in the country.
Like
we were pretty functional for
a
brief period of time.
I remember that.
At least according to some of the polling data at the time. So, I mean, that was the snapshot early on. The split emerged pretty quickly. I mean, it emerged in 2020. It didn't take years. It was before the vaccination. That it got worse when the vaccines rolled out, but the split began sort of that, if I remember correctly, early that spring.
Yeah, and I remember, walking down the streets of New York, going to the hospital, right? Everyone was fearful, but I remember those claps on the street, and that is certainly how we felt, kind of on the front lines. That sense of, unified messaging and communication. So when it comes to what happened after, what do you think were the things that we did well? And when I say we, I'm talking about public health at large, when it comes to communicating. And what are some of the areas that we kind of went awry?
There's lots and lots of words that have been written about this, and many, postmortems and discussions. I I mean, one of the things, and I don't want to overstate it, because I basically think what you have to remember above all, the people up there from public health, the people communicating to the public, what they were trying to do was save your life, right? And the life of your grandmother and the life of your next door neighbor. They were trying to save lives. Was it flawless? No, it was a crisis. It was fast moving. And I think that it was a new, it was the novel coronavirus. Like, it had never been seen before. It's different than other viruses. We still don't really understand all the what they call sequelae, the after effects of this virus. There's still people who are having sort of unexplained health problems. So they were facing something urgent and new. Did they strike every note correctly, perfectly? No, but the overarching messages, I mean, they never said, this is a magic bullet. They never said, this will fix it and make it go away. There was a lot of controversy, a lot of criticism about the messaging about masks, but they also, the cliche in public health was, Swiss cheese, that we have a bunch of things, none of them are perfect. We layer them together and we're going to, maybe not perfect protection, but better protection. I think Josh, as a communicator, as someone who's been a public health official, can talk about, looking in retrospect, some of the things that might have been different. There were it was also an election year, remember, right? I mean, that created another series of tensions and dynamics for the administration. The economic damage is nothing, economic damage is probably inevitable when there's a pandemic, but it's not in the interest of the people who hold office. It doesn't mean it wasn't mean that they went up, got there. I'm not saying they got up there every day and just said, this is what we need to say to win the election, but it was sort of in the backdrop, right? I mean, we were in an election year. So, I mean, but I'll sort of flip it. Josh and I actually teach about this, but he gave the class most on point. He had interesting things to say, so maybe he wants to pick it up.
Yeah, please, Josh.
What I would say is it is natural, particularly within the health field, to focus on the question the way you asked it. What did public health do wrong? What could public health do better? And it's a totally fair question. But if it's okay, we should just take a step back and look at the environment that public health is in and how that's changed. It's sort of like, how did public health steer the boat? But we should pay attention to the fact that the waves are swelling to 15 feet. There's, all kinds of dark clouds on the horizon, and the ship has a leak in it. Public health was underfunded for a long time. There were, where you would have a stable, reliable local media to talk to, that might have been gone. Social media within the political context was very, very polarized, and people were making, all kinds of claims about what public health was saying that's not true. And even responsible reporters were writing very sensationalist stories, would made it sound like, public health was a lot more confident than public health was. So a public health official might say, look, we're not exactly sure what is going to happen, but at this point, it seems like wearing a mask is a reasonable thing to do. And the headline would be public health, wear masks. And in that environment, it's really hard. I don't know that it would have been possible, given the divides in our society, for there to be a flawless communication strategy, because there are people who, have a lot of interest, in some cases, very, very specific financial interest in selling you a product that, has no evidence for it. And that just makes steering this ship harder. Having said all that, I do think there are a lot of lessons for public health. And in particular, I think of the lesson of having a moment to listen to people and what's on their mind as policy gets made. Initially, that could be very hard because, you've got a couple days to make a critical decision, if that. But as time goes on, I think one of the things public health could have done better is put out the kinds of tensions that it's dealing with, how to think about certain kinds of restrictions on bars being open, and how to help the bars if they can't be open as much as they would otherwise be. Get public input on how to navigate those different things and show people the different tensions that are out there, rather than just take a particular step and just be attacked for it as if public health didn't consider the various trade-offs. And I think that that kind of public engagement is really needed now. It would have made a bigger difference then, would have helped people appreciate the challenge the public health officials were facing. And the failure to do that really, I think, contributed to the sense that people had that public health was sure of itself, was arrogant, and that certainly hasn't helped us as the years have gone by.
I couldn't agree more. I mean, so you're two very salient points there. One, that public health has been, as you mentioned, underfunded for years, right? So if we had better infrastructure around our public health interventions, ability to surveil, and so on, we might actually have more insights into what works and what doesn't in real time rather than waiting a matter of months. So totally appreciate that. And I think you're absolutely right. I mean, this question is really geared towards the time after the initial, few months, right? How did we communicate uncertainty? How did we kind of communicate what we know and what we don't know, and that natural tension? I think you beautifully summarized that. Lamari, do you agree with that point? I mean, is there a way that we are going to be able to communicate uncertainty in a better way and to actually listen? Because I'll tell you, I find that right now in a lot of our discourse across public health, there are initiatives like yours, different podcasts, right? Different conversations happening to try to build common ground with different groups like MAHA, let's say. But for the mainstream, what I'm seeing is just more silos. People just kind of digging their heels in and not necessarily listening to one another. So Lamari, if you can comment.
Sure, absolutely. Well, first I'll say one of the things I think we did well was, stand up new ways to share knowledge and expertise, and share the knowledge and expertise that we had based on this novel situation, and also from previous work planning and preparing for such a situation. And we were able to get a lot of expertise and knowledge out to people in different formats and channels. I think we, of course, absolutely learned from the experience, and that the whole pandemic was, I don't know, let's call it like a 3-year journey. So we can talk about the first, month, and then the first 3 months, and the first year, and where we went from there, and of course, the context around it, and also the real world impacts, layered on for folks. And so, absolutely, we are thinking a lot about how to listen and adapt how we share knowledge, and thinking through the implications for different specific groups, and also trade-offs, as Josh mentioned, in terms of understanding the trade-offs of different recommendations. And so, we absolutely, it might seem like silos still online, online often feels like echo chambers and silos, but I do think there's a lot of real world conversations, partnerships, listening, learning, and figuring out the way forward, because there's a lot of people that share similar goals. We all want healthy families, healthy communities, and we want to get there in ways that reflect all of the nuances of life and different groups and individuals. And so absolutely, it is something that we're working on every single day.
Got it. Do you have any examples that you can kind of tell our listeners? And this could be for anybody, just about what you're saying.
Sure, absolutely. Josh and I have been on a little bit of an in real life listening tour. We've been going around and meeting with different organizations to understand, some of their health goals and priorities, and also how they're working with communities in real life. So I think I can share, one example. We've been chatting with the Y of Central Maryland, which is based here where we are in Central Maryland, and learning about how their community health workers work hand in hand with the community to really understand what the community needs, challenges, perspectives are, and thinking about how we can get our content, knowledge, expertise into the hands of those community health workers and let them be the trusted messengers in their community, where they can kind of really tailor what we're offering with what the community needs. And I think in having these conversations, we've learned this is not going to be a fast blast across the internet that's going to solve, this and pave the way forward. It's going to be ongoing work in relationship building and understanding different community needs, and seeing how public health can help achieve those shared goals.
Right. On the one hand, it's not going to be a PSA that says stay tuned for the expert to answer, all the key questions. That's not going to work. But on the other hand, we're definitely understanding that there is interest in getting good information, that has not gone away. And so putting ourselves in position and putting people who really do understand the answers to really important questions people have, putting them in a position to share information um, in a way that is really accessible and trusted. That's really where we're headed. And the idea of one spokesperson speaking authoritatively, I think is probably going to be for the history books, given the way that the world is now working.
Yeah.
There was a really interesting project in Richmond, Virginia during the pandemic where the Cancer Institute affiliated with the University Hospital there, it's it may have been the first, or it's certainly one of the very, very early. The director was a Black physician, a Black oncologist. And he and his colleagues, their counterpart to Morale there, to Lamar, they got together. I think it was a weekly, or maybe it was a bi-weekly. It was 5 years ago. I don't remember every detail, but they got together faith leaders, and they got them on a Zoom. I think it was every other week, and with this hotshot oncologist who also had been from the community like that, and they brought on guest scientists who could speak in plain English. So they were a safety net of accuracy and knowledge for clergy who are trusted communicators, right? There was a lot of outreach about vaccination in churches, not just Black churches, churches in general. When Mike Pence was trying to get people, this was given the politics of masks, this was a short-lived attempt, but he went to Dallas and went up to a great big mega church with a pastor who was also pro-mask, and the two of them stood there in their masks during Sunday services. So I don't know that other communities knew about that or followed that, but it's really a great model where the trusted communicators, community health workers we just mentioned, or clergy is really important. Parent groups, so ways of getting community voices and making sure they're accurate, helping them, so they could go out, because people do trust them in a way they don't trust a stranger on TV in a white coat. But also this sort of propped up the accuracy and the spread of knowledge of something that was changing week to week. Our knowledge, new variants came. They were, it was a crazy time. It was hard to keep up. So I think, maybe they should have, tweeted themselves more and had other communities. We don't mention it in the book. I wrote about it in a magazine piece once. But I think there probably are things like this around the country, and we may have to figure out more ways of connecting all of us who are worrying about public health communication. Who are our partners that we might not totally be aware of, and how to support them with knowledge and accuracy.
I agree.
Sometimes your story, you don't want to platform somebody who's wrong, who is spouting something that I know to be harmful. I don't want that voice in an uncritical way in a story. We're obligated to tell both sides, but that doesn't mean we have to tell correct and incorrect. We have to incorporate voices. We have to understand that we're reporting on a big world.
What if most of the credible messengers, though, you don't have 100% agreement on what you think is accurate and what they might think is accurate, right? Because this is the big question in implementation of a lot of these sciences, is that you're not always going to have 100% agreement. So how do you bring those two tensions together? Understanding that a lot of those credible messengers are not going to agree with everything that we agree with.
Well, one of the problems is that the messages from government health officials right now are different than the messages from government health officials a year or two ago. Instead of saying, here's all the vaccines and these are the things we recommend to your that your children get, some of them are sort of like, you decide, go talk to your doctor, think about it. Some of them have some of the recommendations have changed to be much softer. Just yesterday, there's been mixed messaging about, a drug that may or may not help autism. Yesterday, the FDA said, whoops, we were wrong. It doesn't help. So, in sort of this, the confusion is coming from many, many sources. It's not, who are the trusted communicators and where do they get their message has become a more complex process.
Mm-hmm.
And also there are people who you may disagree with on vaccines, but agree with on food policy, or at least parts of the food policy, maybe not all of it. You might just say, I'm not a MAHA person, but they are right about, some of the causes of chronic disease. Where can we find common ground, right? Maybe not on every element, but I mean, I sort of think that common ground is a good thing for society. Like there's some things we have to agree on, and finding those starting points, even if they're small, and even if the gap is huge on other things, like the gap on vaccines is huge, right? Yeah. I mean, it is not a secret to say that the Secretary of Health, Robert F. Kennedy Jr. is whether you want to call him a vaccine skeptic or anti-vax, whatever, he's not a champion of vaccines, right? That changes. It undermines what people were told just because he is a figure of authority and the people he appoints are now in positions of authority. It's a different message. It's a much more ambiguous message. Mm-hmm. So, where the trusted communicator in the community gets their own information. I mean, we're told, that it used to be that people were going online saying, I'm doing my own research, but that's what they're sort of being told to do. I've been covering healthcare for a lot of time, and I don't have a PhD in biochemistry. There are questions I have to rely on somebody to tell me what is safe and appropriate and desirable to do. So, there's some messages that are pretty clear cut, and there's some messages that are way more muddled than they were a year ago.
Mm-hmm. Mm-hmm.
I think it's important. Yeah, I would just say I think it's important to distinguish between trusted and credible.
Yeah.
Because those have slightly different meanings that are relevant here. Trusted is anybody who people turn to. They're trusted by that person. Credible, I would say, is a statement more about accuracy, whether or not what they're saying is basically right. And, unfortunately, the situation is there's some people who are trusted who are not right.
Yeah.
And how do you deal with that? I do think that there is an area of complete agreement, then there's an area of close enough, you can work with, but then there's an area of not close enough. The people are saying things that really mislead, and they're contributing to this diagnosis that we talk about in our book called information sick. And that's a problem. And in part, it really is about establishing people who truly are credible and working with people who are trusted, but getting them credible information and trying to bring that trusted and credible together. But that may mean telling people that they are so far out of what is correct that they really are not credible. And, those are hard conversations, but you have to have them. I mean, we just can't say because you're trusted, that's good. And we'll accept that you think that, it's a terrible idea to vaccinate, for example.
Yeah. Yeah. Well said. That's such an important distinction. And I think you're right. I mean, there has to be a line, right, where you just kind of agree that you're going to disagree on this issue. And, I wonder what your thoughts are on, we characterize MAHA, for example, as a monolith. And I found in a lot of my conversations with folks in that movement, there's a lot of diverse different opinions, just like there are in the, let's say, public health establishment kind of movement.
I think it's important not to go by an overall label that someone has, and you really have to look beyond to what people are saying. There are people who may call themselves MAHA or completely reasonable on things from my perspective, and certainly within that realm of, close enough. But then there are people who absolutely are not and are actually making people confused, selling them things that they don't need, and putting them and their families in harm's way. And we can't be shy about saying that.
Yeah. Yeah. So what have you seen things that are working with respect to getting credible public health practitioners to really listen, right? Because I just want to go back to a point you mentioned earlier. Listening means having an open mind, right? And I think you brought this up, right, during the pandemic. We could look back, and it's easy in hindsight, totally agree. I mean, we all thought we were going to die, right? Patients were dying. It was a scary time. But just looking beyond that, we didn't necessarily have the right amount of empathy for the person who owns a bar or a restaurant or the shawarma truck owner who didn't have business for 6 months, right? Have you seen things working to actually get credible messengers across public health, some of the leaders in that area to actually listen? Because like I said, I mean, I'm seeing a lot of kind of further divisions on both sides.
I'll tell you the challenge here, because occasionally people called me during the pandemic, and I almost always said, why don't you put out what you're thinking in draft and get comment or have meetings and, think about it and show that you're struggling with this, because I can tell you're struggling with this, but you feel this need to just come out and be definitive right at the outset. And it's really, really hard for people to do that. They feel like they're going to appear weak. They feel like everybody's expecting them to have the answer and they have to deliver it. I think it's really important. And Joanne and I are actually teaching our course now. And one of the things we say is like, it's not weak to do that. It's a show of confidence that you can be open-minded and put out an idea, but be ready to hear about it. And I think it is very hard. And I'll just say also, taking that step back, a lot of times, the elected officials have an expectation that the public health official has that answer, and they want to know exactly what it is right now. And they don't want the public health official to say, well, it could be this, it could be that. Let's get some, public input on it. But that's a conversation that we have to change. So I do think that there's a lot of interesting discussions happening now and we're participating in some where people are getting together and sharing their ideas. I think it's important to realize what we're not talking about is saying, let's find the biggest public health hater out there. Someone who is marching around with a gun on a public health official's lawn, which did happen during the pandemic, and try to find common ground with that person. That may not be realistic. But there are a lot of people who, have questions and are wondering what's going on and trying to find those audiences and those discussions. I think a lot of that is happening. But for public health itself to change and for it to be more the rule than the exception, that we put out things in draft and we listen before making a policy, I think we have a little bit of a ways to go, and it's very hard for people to make that transition.
Well said. Well said. And honestly, not at this point, not very well accepted either, I would say, across academia. And I think that's something, we probably need to work on. Lamari, where are people, I totally agree. I mean, people want good information. There's a desire for that. And I think the majority of Americans have that common ground. They want to have that conversation. They want to know where to go. And there's a lot of confusion. Lamari, where are you seeing people go for that information right now? And how are you guys trying to get them to go to the Hopkins website, right, to start finding that information versus social media?
Sure. I mean, it's definitely challenging right now. I think we see people, a bit in their echo chambers, right, because of the sources where many people go to social media platforms. And then the more you click on something, the more you get more of that same thing, as opposed to a different point of view or a different source for that information. And so we are really focusing in on, where I used to want people to come to us. I wanted us to be a go-to, trusted, credible source. Again, we're thinking about how do we get our knowledge and expertise into the hands of people out there doing meaningful work in communities, really listening and understanding, and bringing that into their work so it's embedded, less about bringing, visitors to our website or our own social channels, and more so making the information accessible so that those who are engaging on these issues in community have it available to them to bring into their work. And really, we've been thinking a lot about just where is there kind of unmet demand for public health expertise that can fit into a problem that a community is trying to solve, or that a community together, wants to improve, an issue that they want to improve in their community. They've identified that issue, and we have expertise that we can bring to the table, and that could be through online channels, but it also is going to be through having our folks be a part of that, those conversations and co-creating solutions on that issue in that community.
Agreed. Joanne, when it comes to the storytelling part of this as well, I mean, one thing that was mentioned earlier is how do you kind of bring out some of the natural tensions that do exist, right? In some ways to make people feel heard and to empathize with what they might be going through. And we've talked about this ad nauseum in multiple other forums. There are countless cases of thousands of randomized control trials, right, supporting something. But a small pocket of patients might have experienced something that they have a grievance with that has impacted their life, and they're passionate about this issue as a result. How do you bring those elements into storytelling to be able to make those folks feel heard while still kind of moving the agenda forward? Because I think that's an important part of relationship building and finding common ground.
I often go through private providers. I don't want, I mean, I'll talk to patients or I'll talk to community members. I went to a senior center it wasn't rural Virginia, but it was sort of exurbia Virginia, in a conservative community. I went to a senior center and talked to them about misinformation and what they were hearing and how. And these were people who were not on TikTok, right? Well, actually, some of the grandmothers were because their grandkids were. So where were you getting information? What were you hearing? And how they were contextualizing it. And with older people, they're very targeted by misinformation, including financial fraud, and they're vulnerable, right? And so that was one where I really sort of was able to sort of platform confusion and how do people sort through things. And the nurse who ran that senior center was sort of my provider voice, like here's what I'm trying to teach them. Here's how I'm trying to support them. Here's how I'm trying to connect them to places of care or places of expertise in the community. Sometimes your story, you don't want to platform somebody who's wrong, who is spouting something that I know to be harmful. I don't want that voice in an uncritical way in a story, right? Because we're obligated to tell both sides, but that doesn't mean we have to tell correct and incorrect. Mm-hmm. We have to incorporate voices. We have to understand that we're reporting on a big world. But I'm not going to put somebody who says, everybody I knew died from the shot next to a leading vaccine scientist on equal grounds, right? I'm trying to find ways of communicating that are, and I write for a lot of different kinds of publications. So I write, some are more grassrooty kinds of things. And I'm on a podcast, so we have I don't know who our audience is, but people who want to learn more about health. So it's not a simple question. I mean, yes, you have to I write a lot about distrust. I mean, it's sort of a sub-theme in almost anything I write, that this crisis of trust. So you want to write about ways of bolstering trust without creating these false equivalencies, because it's not my job to platform someone whose information is going to harm you. Mm-hmm. And I guess I want to say one, like, the media is getting weaker by the day, right? I mean, most of your listeners know what just happened to the Washington Post. There are layoffs expected at many other places. Traditional media is shrinking, and social media, in terms of factual accuracy, is a pretty mixed bag, right? But we've written a lot about the collapse of local news, and some of your listeners probably are in small towns. That's when the local news goes away. That was trusted. It's still trusted. It just doesn't exist in large parts of the country. There's just no local news anymore. It's not only how do I and other journalists like me navigate this landscape of misinformation and distrust, but where can people get their news from? There's no accuracy tests on Twitter, far from it. Right. So that's a huge challenge. There's Josh alluded, there's some really good nonprofits, but they're still, with a few exceptions, they're small. They're not all going to survive. So we're in something, what is the next, where are we going to get accurate news from in the future? I think it's a big and scary question, because also ownership of surviving media outlets is moving. It's overtly conservative companies they're not dominating everything, but overtly conservative ownership with overtly conservative views are becoming more visible and more powerful in the media landscape. And information, I mean, before Josh, the last thing I say, and then I'll stop this, is like, I think people don't understand how sticky, which is the word researchers use, I didn't make it up, how sticky disinformation is. Yeah. Once disinformation gets lodged in our head, whether it's, about vaccines or fluoride or, there's so many things right now, mental health, drugs, there's so much disinformation out there. Once it penetrates our brains, we are not very good at extricating it, right? It really stays with us. It's a huge challenge. There are lots of people studying it. debunking and pre-bunking, and there's all sorts of research. We just don't really know how to restore people to where they were before this got in and implanted itself and stayed in their heads.
Yeah. Yes. Josh, I mean, can you answer that question?
Well, it's good that people trust their clinicians. I think, we cannot, by and large, the most trusted place for health information is a healthcare practitioner that you work with. And certainly for vaccines, pediatricians, I'm a pediatrician, very, very highly trusted. Hopefully they can be an anchor in the storm, keeping with my nautical metaphor here, for a lot of families and a lot of people. But it's hard. I think a lot of the information coming out of the CDC is not credible. And that is just an astonishing statement to say. And so if I'm having trouble, with where information can be trusted, I imagine many people are. And it can be hard, but I think we're going to have to really focus on the in real life world. There's so much misleading information, interested parties, people trying to get you to buy things online, all kinds of challenges now, particularly in this environment. It's really important for people in our line of work, getting good information to people, combating information sickness, to be doing that treatment in person, to be working with community health workers, like Lamari said, to be working with faith leaders, like Joanne said, to be supporting clinicians and getting information to people in the world, because, that is where the impact of people's decisions play out. So, I mean, I do think that if there is any kind of silver lining, it is the recognition, again, that what matters in person here, and the actual talking to people and listening to people in the presence of them, is going to be increasingly important.
Well said. Well said. And the preservation of that clinician to family patient relationship, just like you said, I mean, that trust is certainly there. And I think that, again, probably speaks to the empathy, the relationship, that long-term trust. And I agree. I mean, I think clinicians need to be better equipped with these conversations. I think a lot of them don't know where to go, to be honest, right? It's confusing to clinicians as well, because public health is about real world implementation, very different than controlled experiments. And I think guidance on that and the work you guys are doing is instrumental.
Yeah, and we do a lot of work with clinicians and with organizations to help clinicians, but I think it's important to be doing even more.
Yeah. Well, thank you guys for being here so much. We have run out of time. Lamari, I'll just quickly close with you. What, based on all the work you three do, what kind of keeps you optimistic? It's easy to feel like we're not able to make headway on this topic.
Like I said, we share the same goals. We want healthy families. We want healthy communities. Public health ultimately is about preventing illness and injury. I think we all want that. And so, keeping our eye on that, and that ultimately we all share that goal. And, there's a lot of noise, there's a lot of different players, but ultimately that's what we're working towards. And I think that's what most people are working towards, and that we have that in common.
Thank you. Well said. Well said. So thank you again for being here with us today.